Hello, thank you for joining the ERJ podcast. My name is Dr. Don Sin. I'm the Deputy Chief Editor of the European Respiratory Journal. Today I'm joined by two guests, Dr. Kelly Chin and Dr. Marius Hoeper, to discuss their latest papers that were published as part of the World Symposium on Pulmonary Hypertension. Dr. Chin is a professor of internal medicine and the director of pulmonary hypertension clinical research at University of Texas Southwestern Medical School in Dallas, Texas. And Dr. Hoeper is a professor of respiratory medicine at the Hanover Medical School in Hanover, Germany. Hello, Kelly and Marius. Many thanks for joining us today.
Hi, everybody.
Thanks for having us.
Kelly, could you provide a brief summary of the main recommendations from your paper, Treatment Algorithm for Pulmonary Arterial Hypertension, and perhaps give us a bit of an insight on how you came up with the recommendations?
Yeah. So as you mentioned, the World Symposium met recently, and this is a roughly every 5-year meeting where experts in pulmonary hypertension meet to discuss key advances. And the individual task forces each take on a topic, and ours was the treatment algorithm. So the behind the scenes part, was about a year of a group meeting to go through all of the updates since the last World Symposium, as well as in particular since the last guidelines. So any new developments and studies and so on. And then these were discussed with a larger task force to come up with final recommendations where we interacted with a larger group of experts in PH in Barcelona. The recommendations start with initial treatment and then follow-up treatment recommendations based on response. And throughout this, mortality risk is weaved into these recommendations, partially because some of the PH medications that we use, like intravenous ciprofloxacin or sotatercept, the recently developed medication, have both tremendous benefit, but also some risk and side effects associated with them. So we want to make sure that we're getting the right medications to the right patients. And one of the key advances was obviously sotatercept, which was approved in the last year. And so this now gives us medications acting on 4 pathways. And with maximal medical therapy now, a combination of a PDE5 inhibitor or riociguat, an endothelin receptor antagonist, a parenteral prostanoid agent, and sotatercept. So that's a lot. But the algorithm, starting at the top, is first thing, making sure you have the right patient. Many patients who have pulmonary hypertension don't have group 1 pulmonary arterial hypertension, and this pathway wouldn't be appropriate. The other thing is looking very closely at patients with comorbidities. Some algorithms in the past had a separate treatment pathway for these patients, but we overall felt that many patients who do have comorbidities truly do have group 1 PAH and may be appropriate to be treated with the overall typical algorithm, while others that we may initially think have group 1 PAH may actually have occult left heart disease and just really need to be looked at very carefully. Okay, so getting into the algorithm. Initial therapy for patients who are not at high risk is recommended to be the combination of a PDE5 inhibitor and an endothelin receptor antagonist. That is unchanged really from prior algorithms. And initial therapy for patients at high risk is those 2 medications plus a parenteral prostanoid. And this also is unchanged from prior recommendations for at least the last 5+ years. Then at follow-up, we recommend repeat risk stratification. This should be done at 3 to 4 months or earlier if a patient's deteriorating, and then consideration of add-on therapy. And this is where it gets a bit complicated. There are 5 different potential options you could consider in a patient who was on 2 drug therapy. So for the group that started with an ERA and a PDE5, the potential at this point is add-on therapy with an oral prostanoid, an inhaled prostanoid, a parenteral prostanoid, sotatercept, or switch from a PDE5 inhibitor to riociguat. And so how do you work through that? So we spent a lot of time on this. For the sickest patients, the overall evidence base is still IV or subcutaneous prostanoid. So epoprostenol, IV treprostinol, subQ treprostinol. If the patient is already on those and is still quite sick, then the recommendation is sotatercept, because in the way it was studied, a large percentage of patients were actually on triple background therapy. So we have solid evidence for benefit there. And then for the low-risk patient who's doing quite well, the recommendation is to continue ERA PDE5 therapy. Where it gets complicated is those in-between patients. And overall, looking at the studies, and we have a nice table in the paper that goes through each of these studies and what background therapy was, and what the primary endpoint was, and so on. But looking at these studies, we felt that the evidence base for sotatercept and selexipag was higher than the other options that I listed for this subgroup of patients. And that's based on both the overall trial results, the AE profile, and that a large number of patients were on 2-drug background therapy. So I know that's a lot. Even from their serial risk reassessment that is recommended, with potential changes in therapy and also consideration of timing and referral for lung transplant evaluation.
Very good. These therapies are generally quite expensive. Were costs included in the treatment algorithm or cost effectiveness?
We did not, for a couple of reasons. One is that sotatercept is quite new and we don't have good information, at least worldwide basis, of what the costs were going to be at that time. More information is coming out on that. Second is that there haven't been good studies looking at that, which we would be able to rely on. Is going to be difficult to do because of the way the medications were studied. So with very different endpoints and very different lengths of the studies and the type of patients in the studies, I think it would be a difficult analysis to make at this time point. However, we did make some attempt. We had one group member that was assigned to work on the limited resource setting because I think this is a very important worldwide consideration. Right now, the only medication that's reliably fairly inexpensive is the PDE5 inhibitors. And that's a real problem because we know monotherapy is not as effective as combination therapy. So I think we have a lot of work to do in that area.
In the document, you talk about shared decision-making with presumably the patients and maybe even the payers. What do you mean by shared decision-making, and how would a clinician implement this in a clinic?
I think that's a topic that increasingly is brought to the forefront in medicine in general, is involving the patients in complicated decision-making like this. I start with patients at my first visit and just straight up ask them what their goals are. And I think that's particularly important for some of our older patients who may not have group 1 pH and where we're going with that. But then from the treatment standpoint, I think that there's so many differences in lifestyle that you end up with medications that it's really important to lay that out while at the same time not overwhelming folks with the treatments. So I'm not going to talk about every option as I've laid out in the paper. That would be a very lengthy discussion. But for many patients, there's a couple of options that may be reasonable that we'll go through.
So a fulsome discussion should be undertaken before embarking on any therapeutic algorithm. Is that the bottom line?
Yep.
That's a good segue to you, Marius. Could you provide a brief summary of the main recommendations from your paper entitled Risk Stratification and Treatment Goals in PAH?
Sure. Kelly just indicated that risk assessment remains an important tool to guide treatment decisions. And one of the main statements from our task force on risk assessment and treatment goals was that in patients with PAH, so not other forms of PH, but PAH, non-invasive risk stratification with validated risk scores that utilize WHO functional class, 6-minute walk distance, and the natriuretic peptides. And they remain essential components, and they continue to serve as a useful basic assessment of disease severity and predicting survival. However, and I think this is something that's a bit newer, is that we also noted that it is essential to recognize that none of these variables, functional class, 6-minute walk distance, natriuretic peptides, even none of them are disease specific, which may restrict their suitability for guiding treatment decisions, particularly in patients with comorbidities. So this is quite important. And we propose that parameters or variables suitable for informing treatment decisions should fulfill some key criteria. Of course, they need to possess prognostic value, but they should also directly reflect the severity of pulmonary hypertension and or right ventricular dysfunction.
In the document, you lay out certain objective testing that clinicians can do, such as you've already mentioned, BNP and 6-minute walk test and cardiopulmonary exercise test and invasive hemodynamics. Is there a hierarchy to the order in which these tests should be done? And in resource-scarce settings, what would be the best 1 or 2 tests that clinicians can implement?
It's intriguing because we have now so many data especially from registries, but also from clinical trials all over the world, really telling us that these simple non-invasive variables, functional class, 6-minute walk distance, BNP, NT-proBNP, they are the most important predictors of outcome. That is for sure. So to predict outcome using these tools, especially combined, this is quite helpful. But then again, these are all variables that are affected by so many other things than just pulmonary hypertension that we need to be careful when it comes to making treatment decisions, especially in patients with comorbidities. So we really believe that we should put more emphasis in the future, again, on hemodynamics and on right heart imaging, which is mostly echocardiography and sometimes MRI, as this is much more disease specific and therefore be more useful to guide treatment decisions. And I'm very glad that we have multiple tools to assess disease severity and mortality risk, as we need multidimensional risk assessment, that's for sure. However, and this is sometimes reality, if you allow me only a single tool, I'd probably personally choose echocardiography because it's non-invasive, it's relatively cheap, yet providing comprehensive assessment of right heart and left heart function, always bearing in mind, of course, its dependence on the experience of the investigator.
And what's the role of multi-dimensional composite scores for prognostication? And I think you mentioned in the document REVEAL and several others. Is this ready for prime time, or is this still in development?
No, it's ready for prime time. It's being used. It is recommended in the latest guidelines already. So it's a very clear recommendation also which tools can be used. There's not a single tool. There are several tools that have been validated, and I think the performance of these tools is more or less the same, especially when it comes to clinical decision making, and it's recommended to use at least one of these tools in order to guide these decisions. But again, it's not sufficient if we rely only on the non-invasive assessments, unless it include at least echocardiography, which is what most centers do.
Very good. And maybe this is a question for both of you, and I'll start with Marius first, and then I'll get Kelly's take on it. Just merging the treatment algorithm and the risk stratification together. Let's say a patient, after starting therapeutics 3 to 6 months later, comes to you with improvement in symptoms, WHO class, but no significant change in objective measures. How would you recommend that clinicians proceed? Should they continue with the therapeutics or back off on some therapeutics? And if the scenario is reversed, if the patient's feeling worse, but the objective testing is stable, should clinicians stay on the course of the therapeutics, or should therapeutics be enhanced?
Okay, I mean, stable is not stable, meaning that you can be stable at a very advanced disease or stable at an early stage of the disease where everything is fine. And this is probably something we need to learn in the future, especially when we discuss true IPH. I'm talking about younger patients who have no major comorbidities and no flavor of left heart disease or lung disease, so true IPH. My vision here for the treatment paradigm and for our strategy and for our goals is to enable these patients to live an almost normal life, have a good quality of life, very little impairment in exercise capacity, and the perspective of also having a more or less normal life expectancy. We will achieve this only if we normalize or near normalize hemodynamics and unload the right ventricle. We may not have to fully normalize the hemodynamics, but we have to get in a zone where we can tell and where we have data that this is associated with a good long-term, true long-term outcome. And we don't have the data for this yet. Most of the data that we have generated over the past couple of years are up to 5 years, but we don't have a decade or decades, which we need. And I think for this, we have to go back to the hemodynamics and RV function and the imaging key. And we need to make sure that we get to a point where patients have a control of pulmonary hypertension, so a level of mean PA pressure and pulmonary vascular resistance where life expectancy is more or less normal in most of these patients. And this is something that we need to define. I think this is one of our main goals in the research for the next couple of years, to refine this strategy and define cutoff values for pressure and pulmonary vascular resistance, and especially where we can say if we reach this, then the patient has a very high likelihood of meeting these treatment objectives.
Yeah, I would echo that. And I think also if I'm seeing a patient back in follow-up whose PVR really hasn't budged on combination oral therapy, I'm generally quite alarmed with that. That's, the average improvement with 2 medications is a 40 to 50% drop in PVR. So if it's not moving, we are likely to be in serious trouble pretty quickly with that. As to exactly what to do, most studies in PH have added on therapy rather than done a transition study. As we have more effective therapies and more options, it would be, nice to have some of those studies as well. But for the moment, my inclination is to add on therapy.
Is there anything else of importance that you would like to convey to the ERJ audience?
I think we've briefly alluded to sotatercept, and Marius can tell us more about that as he was part of the studies. But I think it really is a major advance, and we're very excited about it. But there's also a lot we need to learn about it as well moving forward.
Yeah, I fully agree. Sotatercept is what many of us consider a game changer, simply because for the first time, it is a drug that seems to really have the capacity of reverse remodeling, of at least partly reopening some of these occluded vessels that cause the disease, that drive pulmonary arterial hypertension. This is the main reason why I believe that our treatment paradigm is going to change in the future, especially if some other treatments that are currently being developed also fulfill this goal. Then we can truly think of reverse remodeling and reversing pulmonary hypertension to a meaningful or by a meaningful extent. The problem is that we still have some concerns about the long-term safety and tolerability of sotatercept. So the books are not fully closed. It's a new drug. We don't have long-term data, and they're still concerned that with long-term administration that there may be some side effects that may limit the administration. So far, it seems to be pretty safe, and I very much hope so. And of course, that the pipeline is open. There are future developments, and I think that the treatment paradigm that I mentioned earlier is something that we really start seeing now, that we are moving away from just controlling disease, but to something where disease control is at a stage where patients can live more or less a normal life.
Well, this is tremendously exciting time for the PAH field and for patients. We're now not only talking about disease control, but perhaps disease modification, and perhaps in the near future, disease cure. So thank you so much, Kelly and Marius, for joining us today. And thank you, the audience, for joining us. The ERJ collection of papers from the 7th World Symposium on Pulmonary Hypertension is now available on the ERJ website, erj.ersjournals.com.